This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, a senior attending here, and I'm joined as always by our research fellow.
And I'm Dr. Elara. Today we're looking at a fascinating new study from the journal Fluids and Barriers of the CNS, published in 2026. It's a randomized clinical trial titled Ultrasound-guided versus stereotactically navigated ventriculoperitoneal shunt placement, or the NAVPS trial.
This is a topic that hits home for every neurosurgeon. Ventriculoperitoneal shunt, or VPS placement, is arguably one of the most common procedures we perform. It's indicated for everything from normal pressure hydrocephalus in the elderly to shunt dependency after a subarachnoid hemorrhage, trauma, or infection. But as every resident knows, while it's common, it's not without its headaches.
Exactly. The position of the proximal ventricular catheter is really the key determinant of whether that shunt is going to function long-term. Historically, we did these freehand, but that carries a substantial risk of malposition. Then came optical stereotactic navigation, which is highly accurate, but it requires head fixation and a pretty time-consuming preoperative setup.
And that's the trade-off we're always balancing. We want accuracy, but we also want efficiency. Longer operative times aren't just about hospital costs. They are directly linked to higher complication rates, particularly infections. So if we can find a way to be just as accurate but faster, that's a win for the patient.
That's where this study comes in. The researchers at the University Hospital of Basel conducted this investigator-initiated trial from February 2020 to June 2024 to see if ultrasound-guided placement, which offers real-time visualization without the need for registration or head fixation, could hold its own against the gold standard stereotactic navigation.
Let's dive into the methodology, Elara. How did they set this up?
It was a 1-to-1 randomization. They screened 153 participants and ended up including 134 adults undergoing VPS placement. 66 were assigned to the ultrasound-guided group, USG, and 68 to the stereotactically guided group, STG. The primary outcome they were looking for was surgical intervention time.
I think that's a very practical primary endpoint. For the residents listening, remember that surgical intervention time includes the setup. With stereotactic navigation, you're looking at preoperative planning, registration, and often pins. Ultrasound, in theory, bypasses a lot of that. What did the results show?
The results were quite striking on the time front. The USG group had significantly shorter surgical intervention times. On average, the ultrasound cases were 11.5 minutes faster than the stereotactic ones. The 95% confidence interval was -18.5 to -4.5 minutes, with a p-value of 0.002.
11.5 minutes. In the grand scheme of a long spine case, that might not sound like much, but for a shunt, that's a significant percentage of the total case time. If you're doing 3 shunts a day, you've just saved over half an hour of OR time. But Elara, the big question is always, did they sacrifice accuracy for speed?
That's the most important secondary outcome they tracked. They looked at the accuracy of catheter positioning and the number of ventricular puncture attempts. Interestingly, they found that the accuracy of catheter placement was actually comparable between the two groups. However, there was a catch. The number of ventricular puncture attempts was significantly higher in the ultrasound group.
That's an interesting nuance. Let's talk about that for a second from a surgical perspective. With stereotaxy, you spend all that time front-loading the accuracy. You register, you plan your trajectory, and then when you pass the catheter, you're usually one and done. With ultrasound, you're looking at the screen in real time. It's dynamic. You might start a pass, realize your angle is slightly off based on the real-time feedback, withdraw slightly, and redirect.
Exactly. The paper notes that while it took more attempts to get it perfect with the ultrasound, the final resting place of the catheter, the actual accuracy, wasn't compromised. And when you look at the 6-month follow-up, the VPS dysfunction and complication rates were comparable in both groups.
So the cost of using ultrasound is perhaps a bit more manipulation during the puncture phase, but the benefit is a faster overall procedure with no increase in shunt failure or complications. Did the study mention the types of patients? Was there a difference in age or diagnosis?
The demographics were fairly standard for a shunt trial. The mean age was 73 for the ultrasound group and 66 for the stereotactic group. About 45.7% of the participants were female. They included a broad range of adult patients, which makes the findings pretty generalizable to a standard neurosurgical practice.
One thing I'd highlight for the residents is the technical difference between the two navigation methods. Stereotaxy, whether optical or electromagnetic, is based on a snapshot of the brain, the preoperative scan. If there's any brain shift or if the registration is slightly off, your navigation is off. Ultrasound is live. You see the ventricles as they are right at that moment.
And the study points out that ultrasound-guided placement doesn't require preoperative imaging or registration. That's likely where that 11.5-minute saving comes from. You're not waiting for the software to load or clicking through points on a scalp that might have moved.
It really challenges the idea that we need high-tech stereotaxy for every case. If ultrasound is more time-efficient and just as safe, that's a very appealing alternative. Did the study address the learning curve at all?
The paper emphasizes that USG VPS placement can be efficiently and safely used in clinical practice, but it's worth noting this was at the University Hospital of Basel, a high-volume center. For a resident or a surgeon who hasn't used intraoperative ultrasound much, there's definitely a period of adjustment to get comfortable with the hand-eye coordination of holding the probe while passing the catheter.
That probably explains the higher number of puncture attempts in the USG group. It's a more active form of navigation. But again, the fact that the 6-month complication rates were comparable suggests that those extra attempts didn't lead to more hemorrhages or tract injuries that were clinically significant.
Right. The study conclusion was very clear. USG VPS placement is more time efficient, and the accuracy and safety are comparable to STG. They basically position ultrasound as a very viable, perhaps even superior option for routine shunt surgery because of that time factor.
It's a strong piece of evidence. This was the NAV-PS trial, a randomized clinical trial, which is the gold standard for this kind of comparison. Before this, we mostly had small retrospective series. Having a prospective randomized study really moves the needle.
It's also worth mentioning the trial registration. It's on clinicaltrials.gov as NCT 0450797. They've been very transparent with their data, and the protocol was published beforehand, which adds a lot of weight to these results.
For our listeners who are residents, next time you're in the OR for a shunt, ask your attending about the possibility of using ultrasound. It's a skill worth developing. Not only does it save time, but being able to visualize the anatomy in real time is a great way to deepen your understanding of ventricular volumes and trajectories.
And for the attendings and department heads, that 11.5 minutes of saved surgical intervention time per case is something to consider for OR throughput and reducing the time the patient is under anesthesia.
Absolutely. Efficiency without the loss of accuracy is the goal in everything we do. Elara, any final thoughts from the paper?
Just that this study reinforces the idea that newer or more complex isn't always better. Stereotactic navigation is amazing technology, but for a procedure like a VPS, the real-time simplicity of ultrasound seems to provide the best balance of speed and precision.
Well said. This has been a great deep dive into a very practical study. I want to thank the researchers at Basel for putting this trial together. It's definitely going to change the way I talk about shunt placement with my residents.
Agreed. If you want to read the full text, it's available in Fluids and Barriers of the CNS, June 2026. That's all for today's episode of the Neurosurgery Hub Podcast. I'm Dr. Aris. And I'm Dr. Elara.
We'll see you in the next one. Keep learning and keep operating.